Hello and welcome back, or welcome if this is your first episode with me. In today's video, I'm going to be covering various health topics centering on the LGBTQ population. Specifically, I want to focus on substance use, mental health and social well-being, and sexual assault. As a result, I'm giving a blanket content warning for the whole video. Thank you, and please see the description for more resources at the end. Since 1971, there has been nationwide survey coverage on the use of alcohol, drug use, mental health, and treatment for LGBT adults and youth in all 50 states and DC. Major exclusions from the data include active military personnel, long-term hospital residents, prison populations, and homeless individuals not in shelters. We will get to why not focusing on the prison population specifically can be troublesome later on in the video. Included in the 2022 survey were 71,369 individuals, with specific focus on LGBT adults. Now, you may be wondering why transgender people aren't included in the data. I'm thinking it's because the study focuses on sexual minorities and not gender minorities, but given that many transgender and non-binary individuals are also lesbian, gay, bisexual, etc., you can expect that many of these people will have had similar experiences and or be included in the report anyway. Substance use rates, including alcohol and illicit drugs, are notably higher among sexual minorities. A significant portion of LGBT adults used substances in the past month. More than half of recent alcohol users engaged in binge drinking, with higher rates among LGBT adults compared to heterosexual adults. Vaping was especially prevalent among young LGBT adults ages 18 to 25, with 46.9% vaping exclusively compared to 16.1% of those aged 26 or older. Past year illicit drug use was reported by a majority of LGBT young adults, with 59.2% using illicit drugs and 56% using marijuana. LGBT adults were more likely than heterosexual adults to use illicit drugs and marijuana in the past month. Among marijuana users, about 40% vaped marijuana in the past month. Past year opioid misuse was more common among bisexual adults, who were also more likely than heterosexual adults to misuse opioids. LGBT young adults, from 18 to 25, showed higher prevalence of SUD in the past year compared to older LGBT adults, with an overall higher likelihood than heterosexual adults. Nearly all LGBT adults with a substance use disorder did not get treatment. Mental illness prevalence was highest among LGBT adults, with over 2/3 receiving mental health treatment, especially those with serious mental illness. Sexual minorities, especially bisexual individuals, have significantly higher rates of mental health issues and substance use compared to their heterosexual counterparts. LGBT adults with mental health issues were more likely than heterosexual adults to receive treatment in the past year. LGBT adults, especially those ages 18 to 25, experienced higher rates of suicidal thoughts, plans, and attempts, with bisexual adults showing the highest attempt rates. Bisexual females are particularly vulnerable, showing higher rates of major depressive episodes and suicidal thoughts. Data indicates that bisexual females are more likely to experience serious thoughts of suicide and make suicide plans compared to straight females. About 24.8% of LGBT adults experience both SUD and mental illness in the past year, with young adults ages 18 to 25 most affected. Those with mental illness were more likely to misuse substances than those without mental health issues. A majority of LGBT adults who experience substance problems or mental health issues considered themselves to be recovering or in recovery, yet treatment gaps remain. This next section will focus on advancing health outcomes for intersex people. Intersex is an umbrella term for people born with variations in sex characteristics or reproductive anatomy, referring both to physical traits and an identity or community, the I in LGBTQI+. Intersex variations involve differences in at least one of 7 physical traits: sex chromosomes, gonads, external genitalia structures, internal structures, sex hormone production, response, and secondary sex characteristics. Intersex variations such as congenital adrenal hyperplasia or CAH and Klinefelter syndrome are a natural part of human diversity, but many intersex individuals face medical interventions treating their variations as disorders. Over 5 million intersex people in the U.S. face significant health disparities and barriers to achieving health equity, with current medical practices, especially for children, often causing lifelong harm. Key barriers include non-consensual surgeries in intersex infants, lack of provider training, systemic challenges in healthcare systems like medical records, and medical mistrust, with intersex people of color and those with disabilities facing greater disparities. Historically, intersex variation has been treated as a medical disorder, leading to practices focused on early surgical interventions to conform sex characteristics to a single sex, often causing lasting harm. Growing evidence shows that non-emergent, non-consensual surgeries on intersex infants can result in lifelong harm, including significant scarring, loss of sexual function, chronic pain, and early-onset osteoporosis. New parents often face unexpected and significant decisions about medical care for their intersex child. But historic protocols pushed for immediate surgical interventions driven by social and cultural expectations rather than medical necessity. Parents seeking support often struggle to find accurate and affirming information and may be encouraged towards interventions that research shows can cause lasting harm. Practices like encouraging treatment based on social views of sex, raising concerns about delayed, non-emergent interventions, or concealing their child's intersex status exacerbate medical mistrust and negatively impact outcomes. Intersex adults face discrimination and difficulty accessing services related to major life events like fertility and parenthood. The lack of research on intersex adult health needs means many adults lack access to affirming care, with one study showing 65.4% of participants delayed preventative health care due to prior negative experiences. Systematic challenges, such as medical record systems lacking flexibility to reflect intersex variations, increased medical mistrust, can contribute to treatment failures. Public health research on sexual health often excludes or misclassified intersex people, impeding STI screenings and prevention efforts. Intersex individuals face barriers to fertility counseling and accessing assisted reproductive technology, with only 53% satisfied with how fertility options were discussed. Infertility treatments are particularly relevant for intersex people who underwent childhood treatments and surgeries, but some may be unaware of their ability to have biological children. Due to stigma and discrimination, intersex people experience significantly higher rates of mental health challenges, including depression, anxiety, and trauma-related symptoms from previous medical interventions. Many intersex adults who underwent childhood medical interventions experience repeated genital examinations, increasing medical mistrust and leading to avoidance of mental health support. Including intersex people in public health and biomedical research is essential, moving past assumptions that sex characteristics are strictly binary. Best practices recommend specific inclusive survey questions to ask about variations of sex characteristics without placing intersex as a third sex category. Healthcare workers should recognize the trauma many intersex people have experienced, as routine procedures like cervical pap tests can be re-traumatizing. Clinicians can adopt trauma-sensitive practices by asking permission before performing examinations, ensuring patient privacy, and suggesting alternatives like self-swabs. Shared decision-making must prioritize the intersex patient's needs over those of caregivers and acknowledge sex variations as a natural component of human diversity. This approach contrasts with the historical lack of bodily autonomy many intersex people have experienced. A knowledge gap exists among healthcare workers regarding intersex variation, often resulting in less knowledgeable care for intersex people compared to lesbian, gay, bisexual, or transgender patients. Many professionals mistakenly believe intersex variation is solely a pediatric concern, leaving them unprepared for intersex adult patients. Healthcare workers may unintentionally exacerbate medical mistrust by using language that is not affirming, or by asking invasive and unnecessary questions unrelated to current health concerns. Barriers include the continued use of medicalized language rather than patient-preferred terms in electronic health record systems that fail to adequately record patient-preferred names, pronouns, and gender identity. Practices should ensure informed consent is always used and that disclosure of intersex status is limited to a need-to-know basis to protect patient privacy. Parental acceptance of an intersex child's variation significantly reduces the risk of mental health distress and suicidal ideation. Peer support, including intersex support and community groups, is crucial for building mental health resilience and improving outcomes. Openness about intersex variation is associated with more positive psychological outcomes, including reduced depression, shame, and isolation. Self-acceptance and open discussions about intersex variations can help intersex adolescents and adults appreciate their bodies, thereby improving overall self-acceptance and mental health. For intersex people with traumatic experiences, self-acceptance is important for post-traumatic growth and recovery. Healthcare professionals, including mental health providers, should assist patients in determining the appropriate level and context of disclosure regarding their intersex variations. Family acceptance for intersex youth must be promoted, with healthcare providers modeling intersex-affirming approaches and offering pathways towards peer support. People with lived intersex experience must be included in every effort to implement these recommendations, centering their experiences, health disparities, and successes. Next, we will discuss sexual minorities in the context of incarceration and the criminal justice system. To help LGBT adults who have been assaulted in prison, an immediate response, including victim protection, medical care, evidence collection, and documentation, is required. Often, in same-gender prisons, assault and rape can occur as a means of coercion and control, regardless of sexuality. Corrections staff, healthcare personnel, and community-based advocates have a role to play in mitigating the damage done both physically and psychologically, especially to transgender people who may be placed in prisons that don't align with their identities. Victim-centered care focuses on safety, privacy, and access to services, including forensic evaluations after assault and battery has taken place. It is very important to use independent forensic examiners to avoid conflicts of interest within the prison, as the incident might have occurred between staff and an inmate, especially if there was a prior incident of abuse that went unreported. Let's face it, not everyone in a prison is trained on the dynamics of sexual assault. Therefore, it's paramount to have a coordinated team approach which includes social workers, nurses, advocates, and legal representatives. These are known as Sexual Assault Response Teams, or SARTs, and having one on staff increases the likelihood that the investigation and recovery will proceed accordingly. It's all about safety. Effective responses to sexual assault in correctional settings require comprehensive protocols that prioritize victim needs and ensure accountability for the perpetrators. Finally, our last topic will be on transgender and non-binary inclusion in school settings. There is an urgent need for schools to create safer and more supportive environments for transgender and questioning students. Transgender and questioning students face significant health disparities, including higher rates of violence, mental health issues, and suicidal behaviors. School connectedness is crucial for positive health outcomes, yet transgender students report lower levels of connectedness. Approximately 3.3% of high school students identified as transgender, and 2.2% as questioning. Transgender and questioning students reported higher rates of bullying at 40 and 39.9% respectively, and mental health issues, 71.9% reported persistent sadness. 26% of transgender and questioning students attempted suicide in the past year, compared to 5% of cisgender males. So, how can we make things better? We need to implement inclusive policies and practices such as Gender and Sexualities Alliances, or GSAs, and provide training for educators on LGBTQ+ issues particularly regarding underrepresented racial groups and the need for more nuanced measures of gender identity. Future research should focus on the experiences of non-binary students, as they were unfortunately not included in the data collection for this set. And that's it. Thanks for tuning in. I know those were some hard issues to listen to, but I thank you for taking the time to engage with them. I hope you all have a good day, and once again, leave me comments and I will try to respond to them. Resources are in the description. See you soon.